Welcome, my name is Michael Haude. I'm here with Alex Abizaid and Nick West to talk about the hot topic of bioresorbable scaffolds, current data, unresolved issues, and future developments. Before we start the discussion, maybe I'd like to ask Alex, will you be so kind and summarize briefly what is our current status on clinical data that we have available?
Michael, thank you for having me. I think it's very clear to me that the current data on the two approved devices in Europe, Absorb and Dissolve, there is no question about the efficacy of those devices. I think that the main question that was raised recently is about safety. Probably because this is still first generation devices, a little bit bulkier, and the technique of deployment was not perfected in the early days.
So when we talk about this aspect of safety, the thrombotic signal that is there, that is a little bit higher, Nick, what kind of technical aspects we have learned we can use and in order to improve that safety aspect?
Thanks, Michael. I think this is the key issue for BRS right now. What we've learned from the available data, as Alex has summarized, is that in appropriately sized vessels, the efficacy of these devices appears to be comparable to current gen drug-eluting stents. However, in smaller vessels or when the device is not correctly deployed, this is when we have the higher risk of scaffold thrombosis. Data from large national registries, such as the MECAT registry, have shown that strict application of rigorous post-dilatation in one-to-one fashion, appropriate sizing of the scaffold to the vessel, and then post-dilatation to high pressure can ensure reduction in scaffold thrombosis rates to comparable with metallic drug-eluting stents.
What's about lesion preparation?
Well, I think lesion preparation is absolutely key. These devices are not as forgiving as metallic drug-eluting stents. They don't have the expansion range, and so therefore we must prepare the vessel. We don't have the ability to score the vessel effectively that we do have with a metallic drug-eluting stent when we deploy it. So preparation is key. Non-compliant balloons, a low threshold for scoring or cutting balloons, and some operators may choose to use rotablation or other debulking strategies.
Alex, do we need intracoronary imaging technology in order to improve our implant result, in order to avoid these thrombotic events?
I think that with first generation devices, we should have a more liberal use of imaging, particularly in the beginning of the experience that we're starting to deal with these new devices. I think we learn a lot in terms of deployment technique using OCT and IVUS. But it's not realistic that we're going to use imaging modality in all of our patients. So I think that we're going to learn how to optimize these devices based on a good angiography, perhaps online QCA, Dmax calculation, and we're going to reserve OCT and IVUS for more complex patients and lesions such as bifurcations and very long tapered vessels.
Well, let's consider what kind of future directions and developments do we see with this kind of technology? You have access to several of these second generation devices. Can you give us your personal experience, what we can expect from this?
Yeah, I think that there are a couple of items that we should improve upon, and the basic ones are perhaps profile of the devices. The strut thickness will play an important role, particularly for thrombosis. Also, the fact that you can visualize these devices. It's potentially an interesting feature. As you know, most of polymeric and metallic bioresorbable scaffolds will have only radiopaque markers at the edges because you don't see the device. So perhaps to add iodine or some kind of X-ray compatible device will be interesting to help us with the deployment. But other features such as shorter resorption time to free the device a little bit earlier will be an interesting one, keeping the radial force, the mechanical forces. So I think the combination of these features might help us in the future with futuristic generations.
The final question to both of you. Who in 2016 is the ideal patient candidate for a bioresorbable scaffold? Maybe we start with Nick.
Well, I think in the current space, this device has shown its benefits in relatively straightforward lesions. I think many of us would hope to extend it to longer lesions in younger patients, but equally I think that the current status is that these devices are not suitable for the most complex coronary lesions that we are quite commonly treating in our practice. Alex?
I think this is a perfect answer. I would say that I would think the opposite. Which patients and lesions that I would not treat with a bioresorbable scaffold? Certainly those highly calcified lesions that you cannot prepare the lesion well for some reason. Extremely large vessels, greater than 3.75. With the current technology, we should perhaps stay away from those. Extremely small vessels, perhaps less than 2.5, I would not consider. And those, of course, SVGs and left mains that are generally not compatible with sizing. Other than that, and particularly for young patients, this would be my preference.
Okay. So if you'd like to wrap me up this discussion, I would like to summarize that bioresorbable technology has shown its efficacy in relation to standard of care drug-eluting stents. We do see some little thrombotic concerns with an early increased risk of scaffold thrombosis. Actually, we need to say that we have learned how to properly implant the device, which we didn't maybe did so good in the earlier times. Lesion sizing is important, lesion preparation is important, proper implantation and post-dilatation with non-compliant balloons is of utmost importance. Imaging, especially during the learning curve, is important to get into contact with this new technology. And probably, as with always, with the second and third generation devices, these by itself will improve the outcome and efficacy and safety itself. So therefore, I would like to thank you, both of you, for this interview, and I think we're done.